Hello, good morning and welcome to Cardiology Wednesday Morning Rounds. Today, I would like to introduce Dr. Ahmed to do an update from the recent European Society of Cardiology Congress, and thank you very much for doing this presentation.
Thanks, Dr. Hayden.
I'm sorry, we were talking about the question period, and we thought that maybe after every trial, a little pause for the question period, and then we'll continue with the other trial.
That's good. Thanks so much, Dr. Hayden. So, not to be too ambitious in the scope of this talk, but we thought I would do a recap of some ESC trials from 2025. So the objectives of this are, I'm on the wards right now, and sometimes clinical questions come up, and you're like, oh, what if I did this? So the hope is we'll talk about 6 new trials from ESC 2025. The focus will be on relevant aspects of day-to-day cardiology clinical care, and we'll try to contextualize these new findings within existing clinical practice. So I thought we'd start with a case. Many of us will be familiar to this from the interventional and CCU world. So this is an 81-year-old gentleman with a history of metastatic lung cancer. He comes to hospital with a 6-hour history of chest pain, and his ECG demonstrates anterolateral ST elevations. So he's got a reasonable prognosis from his malignancy. He's clearly unwell. He's in some mild heart failure, but on no real significant oxygen. So we take him to the lab, and as you can see, not a particularly attractive vessel to fix in the sense that there's ostial LAD and the proximal LAD is occluded. So under IVUS guidance via the right radial approach, we wire the LAD, and then we do a provisional PCI from the left main into the proximal LAD. And then we IVUS it, and we do a 4-0 non-compliant balloon. There's all this distal stuff here that we say, look, is best treated medically. So move on, and we do an LV angiogram, and the LVF, as you can see, severely impaired with apical akinesia, and the EDP is 27. So that's the case. It's something that we happen to do as a garden variety STEMI on call. And the question is now you look at the RCA, and angiographically, there is a stenosis of 70%, some would say. It's fairly short, it's focal. And the question is, should we fix this now? Should we fix it later? Should we fix it at all? So the concept I wanted to discuss, which has been advancing over the past 6 years in interventional cardiology practice, is for patients that present with STEMIs and have primary PCI and have all these non-culprit lesions. What should you do? Should you fix them with stents? Should you send them for CABG? Should you treat them medically? Historically, and I think culturally at this institution, non-culprit lesions of angiographic severity have traditionally been fixed. But the RCT data started to come to light more so over the past 6 years. So there were several trials on the subject. The complete trial was a PHRI trial, and one that was ongoing when I was a fellow, that basically took patients that have STEMI and present with STEMI and have primary PCI and have non-culprit lesions, does complete revascularization yield better outcomes? So the way you think about this is, should you touch those lesions or not? And ultimately what complete showed was that compared to culprit-only revascularization, PCI, also the non-culprit lesions, led to a 26% reduction in this composite outcome of cardiovascular death and MI, and that was primarily driven by 32% lower risk of new myocardial infarction. It also led to a 49% lower risk of cardiovascular death, MI, ischemia-driven revascularization. There's other large trials, BioVasc and Lancet, and Multistars AMI and New England Journal of Medicine, and they all demonstrated similar results. So the question now you want to ask yourself is, okay, we probably should fix these non-culprit bystanders. There's a number of different pathways you can take. The first is, well, how should you decide which of these should be fixed? Should it be with intravascular imaging? Should it be with FFR? That's a different story, and there's ongoing trials to address that. The question is, when should you fix them? And I think this was the trial. There's a trial that showed some interesting perspectives on the concept of this. So if you look at all the RCTs that looked at non-culprit revascularization, they were predominantly done in the outpatient setting. So these are, PCIs for non-culprit lesions that were performed variably 2 days, 3 days. Incomplete, it was 23 days post-index MI. So this is a study from South Korea called the Option STEMI trial. So it's investigator-initiated, it's multi-center across 4 STEMI centers in South Korea. It's non-inferiority and it's RCT, and it was conducted with a intention to treat analysis. So the research question here is, in patients with a STEMI, who have non-culprit lesions, should you do immediate same-sitting stage PCI, or do you do it in a stage fashion on a different date? They define multivessel CAD as patients who have non-culprit vessels that are at least 2.5 millimeters in diameter and at least angiographically 50% or more stenoses. And they deem successful PCI of the culprit vessel as less than 20% residual lesion and TIMI 2 and TIMI 3 flow. So the study population was all adult patients who presented with a STEMI, had multivessel CAD, and had successful PCI of the culprit artery. Notably, they excluded late presentation STEMI patients, so those that present 12 hours after symptom onset, those that had cardiogenic shock after initial treatment, patients that had unprotected left main disease of more than 50% severity in the non-culprit population, and then they had a CT of the non-culprit artery. These exclusions are kind of important because each of them, has some evidence to it. So culprit shock basically took patients with acute MI that had cardiogenic shock and then did, immediate multivessel PCI, and that showed harm. So those patients were excluded. So the intervention was participants are randomly assigned in a one-to-one fashion to either immediate PCI, so you fix the culprit vessel, in this case the LED, and then you would go and do the RCA at the same time, versus stage complete revascularization for the non-culprit lesions on another day during the admission. So these were all inpatient stage procedures. So the population was, the approach, or rather treatment strategy, was a little bit different compared to other studies. So in terms of trial design, there was about 500 patients in each arm, and the timing wasn't pre-specified in the staged arm. It just had to be done on the inpatient admission. On average, the median time to the stage procedure ended up being about 3 days. And the only things that delayed clinical care or getting a stage procedure was if the patient had heart failure, vascular complications, shock, etc. In terms of the PCI, how was the PCI done? A lot of the interventional folks will be focused on that. So stenoses that were greater than 70% were treated with PCI, no questions asked. Intermediate stenoses, 50 to 69% stenoses, were evaluated with FFR. Those that were FFR positive were PCI'd, i.e. FFR less than 0.80. And the standard platform that was used was the Boston Scientific Synergy third-generation drug-eluting stent, which is everolimus. The procedural aspects were left to the interventionalists. So the vascular access site, the choice of P2Y12, whether or not they use thrombus aspiration, and the use of intravascular imaging. And they followed up patients at 1 month, 6 months, and 12 months. So the primary outcome was a composite of death from any cause, non-fatal MI, or any unplanned revascularization at 1 year. So the first thing I do when I look at a trial is go to table 1 and try to imagine the patient that would be in a trial like this. And by and large, like most cardiology trials, it's usually a 66-year-old male. And that was the case here as well. So median age was 66, 20% of the patient population was female. Both arms were fairly well balanced. The interesting thing I wanted to bring up here was 33% of the patients in this trial were in heart failure at the time of just enrollment across both arms. So they define that as KILLIP 2 or KILLIP 3. You can see 40% were smokers, 40% approximately were diabetics, and predominantly this is a study of majority anterior infarcts of approximately 40%. So procedural characteristics, 75% of the cases were done radially, so that's a win, it's good. 26% used intravascular imaging, which is on par, if not slightly higher than the standard intravascular imaging rate in Canadian centers. The median time to the stage procedure was 3 days in the staged arm. FFR was performed in about half of the non-culprit lesions, and 82% of these lesions actually had non-significant FFRs and didn't have PCI. And revascularization was performed in 63% of the non-culprit lesions in the immediate group and 55% in the stage group. In a statistically non-significant fashion, in the staged arm, more intravascular imaging was used. I theorize maybe because OCT requires contrast, you're not going to do, give an additional contrast load during the index PCI. So This was the primary outcome. So it occurred in 13% of the immediate complete revascularization group and 11% of the staged complete revascularization group. So it did not meet the non-inferiority margin. So immediate complete revascularization was deemed to be not non-inferior to staged complete revascularization. There was some degree of crossover. Reassuringly, 9% of the patients that were randomized to the immediate PCI group crossed over to the stage group, but the reverse, meaning patients that were for the stage PCI group, meaning they had their PCI to the culprit artery and were waiting for the non-culprit lesions to be done, only 3% of those crossed over to the immediate arm, which is reassuring. Now, the pre-specified subgroups, one of them was KILIP2 or higher in terms of clinical heart failure. And this showed that 23% of patients in the immediate arm had the primary endpoint, whereas 13% in the stage group, meaning that patients with clinical evidence of heart failure actually had a slightly higher risk of the primary endpoint of non-fatal MI, unplanned revascularization, or death from any cause. So the unique parts of this study in compared to the existing literature was that there's a high enrollment of patients with clinical heart failure. Usually those patients would have been excluded in most studies. The pre-specified subgroup analysis indicates that there's some degree of harm for doing immediate non-corporate lesion PCI at the time of the index procedure. There is some nuance to this. If you look at the culprit shock study that I had mentioned earlier in patients with cardiogenic shock, doing immediate non-culprit vessel PCI was bad, was harmful to patients. So if there's any degree of cardiac dysfunction leading to clinical heart failure, it's bad. Don't do, non-culprit stage vessel PCI on those patients immediately. So the bottom line was in patients with STEMI and multivessel CAD, immediate complete revascularization was not shown to be non-inferior to stage complete revas during the index admission with respect to the composite endpoint. So back to our case, this was obviously done before the trial was published, but if you recall during our index procedure, we stented from left main into the LAD. The patient was in heart failure but clinically stable. EDP was 27, and the EF was 35%. So intuitively, I just felt it's probably not a good idea after you've stented the left main to then go after a very short, stable focal RCA. Some people might want to do that. I didn't feel comfortable doing that. So we brought the patient back, and under IVUS guidance, it was just a short focal stent to the distal right. So that's kind of in brief what we do for non-culprit lesions. A lot of us have variability in how we put our catheter ports in. And some of you look at it and we're like, well, why did you want to do this now? And why did you want to do this lesion later? So I hope this sheds a little bit light on that important aspect of how we structure CAD care for non-culprit lesions in STEMI. So maybe I thought we'd pause and then have like a quick little chat about the study. Dr. Birdie. Yes.
Believe immediate vascularization. Tell the difference between a procedure related MI and MI. The patient's having an MI.
That's a very good question. I think in contemporary ACS trials, a lot of the events are driven by our assessment of periprocedural MI. Clinically, we don't treat these any differently. We're expected to have a troponin elevation, usually during the point of index PCI. How much of that is due to the index plaque rupture in ACS clinical presentation versus you transiently occluding flow? But yes, that is a criticism of common STEMI trials. I'm not sure if any of the other interventions would like to comment on that.
Part of the primary.
100%.
The primary, probably could be even more tilted towards scheme treatment, which we would. No, it would be even more negative.
Yeah.
Yeah.
So I think it intuitively follows what we do from a clinical perspective. I think this lends some degree of credence to the fact that we probably shouldn't be doing this on sick patients with deranged heart function or clinical heart failure. They include these.
Even there, also has health economic.
Yeah, absolutely. Culprit shock, I think, was just a bad marker of harm as to why we should even consider doing non-culprit lesions at the time of. Dr. Nair?
elaborate. So it's a concept of death from any cause. And if you look at death from non-cardiovascular load, so it's death from cardiovascular, which I presume is related to the MI and GS2 and 3 because high-risk population. But I think what's driving your event rate is concept of unplanned repeat revascularization. So what was the unplanned repeat? Because was it related to your going after the next question or not? Secondly, people who had another myocardial events like anseplankton, was it related to the arterial lesion that was not that, or was it an entirely new plaque rupture?
A lot of
or a problem in the stent that was deployed in infection. So those will determine, the real story behind this outcome.
Absolutely. I think as with most ACS studies and PCI trials, stent thrombosis rates are typically low. So this is not a consequence of the actual intervention itself, but rather I think a degree of, someone is randomized to the staged arm and someone clinically feels, oh, well, they're having chest pain. I think we should, take this patient for PCI. And I think that's a bias of us as clinical decision makers on the wards is we'll see a nasty lesion and say, well, I think this should actually be done sooner rather than later, or should have been done immediately. So there weren't substantial protocol deviations, and the crossover rates weren't substantial. But I do agree, in an ideal world, I think in STEMI or ACS studies or PCI trials, we probably shouldn't be having target lesion failure or unplanned revascularization. I think outcomes should be more patient-centered, i.e. mortality, clear harm like bleeding or death. I think that's something that trials should focus on. I think the issue isn't for the trials in the room, correct me if I'm wrong, is just event rates being low in an era of excellent medical therapy and treatment. There's just going to be low event rates unless we frame them as composite outcomes. And I think that's what drives inclusion of non-patient-centered outcomes in the composite primary.
Different the part of death from any cause, most of the others are event rates in both arms are not.
Exactly. Yeah. No, for sure.
And this is a higher risk.
Yeah, exactly. Thank you. Anyone else? Any of the interventionalists who want to comment? No? It's reflective of contemporary practice, you would agree? Okay. So the next study hasn't actually been published yet, but is the dual ACS study. So it's an open label investigator-initiated RCT that studied short duration of DAPT, so 3 months versus 12 months, which is the current standard of care in patients that presented with MI. So what was unique about the study, it was very ambitious. They wanted to recruit 18,000 patients. Spoiler, it didn't happen. And secondly, they took an all-comer ACS population. So basically anyone presenting with ACS that had treatment with PCI or CABG or medical therapy. And they effectively randomized them 1-to-1 to either receiving a short duration of dual antiplatelet therapy or a standard or prolonged duration of antiplatelet therapy. So it was run out of Scotland. Oh, I think my audio is cut out here, Faye. Audio is cut out. Yeah, I could just use the mic. Gotcha. All right, I think the mic cut out there. So it's presented by Dr. Newby, and the full publication is forthcoming. So there were 21 sites in Scotland, 100 sites in England, and 7 sites in New Zealand for all-comer ACS populations. So about 5,000 patients with ACS were enrolled in the study, so only about 30% of the targeted enrollment. If you look at the subset of the patients, so 70% were treated with PCI, 20% or so had medication management only, and then 6% had CABG. Patient characteristics, again, as you would think of most contemporary ACS or CD trials in cardiology, mean age was 63 and 70% or more of the patients were male. And the primary endpoint was all-cause mortality. So a nice, robust outcome, non-composite, with patient-important outcomes. So all-cause mortality was 2.7% in the 3-month group and 3.4% in the 12-month group, and the hazard ratio was 0.78. There's no difference in cardiovascular death or non-fatal MI in the short arm versus the standard 12-month arm. And fatal and non-fatal major bleeding occurred in 3.2% of the patients in the 3-month arm and 4% of patients in the 12-month arm. So obviously it fell short of targeted enrollment, and there was issues with the power of the study based off of what they had calculated. But the bottom line was in patients with ACS, there was no evidence that DAPT given for 12 months would confer additional benefit when compared to DAPT for 3 months. And there's a trend toward lower mortality and bleeding risk in patients with ACS when the DAPT was limited to 3 months. So I'll continue on because this is a short study. I'll talk about the next one and then we can chat a little bit. So bottom line is we see trends of, well, should we just do a shorter duration of the dual antiplatelet therapy? Then the question becomes, well, how short? So this study was probably the most ambitious in terms of short, in the sense that immediately after PCI, they just dropped aspirin. So this was an investigator-initiated multicentral open label RCT, and they had blinded outcome adjudication. So this was a Brazilian study. It's called Neo Mindset. So we know that the standard treatment regimen for ACS is aspirin and a P2Y12 of choice, and we do that for at least 12 months. But we know that when you do it for 12 months, patients will have inherently bleeding outcomes, and when they have bleeding outcomes, typically you'll stop their antiplatelets, and then, as it follows, they'll have then potentially stent compromise or ischemic outcomes as a consequence. So a lot of studies have looked at 1 month and 3 month durations of DAPT, and there's been some promising results that it's safe in high-risk bleeding populations. So this study had the research question is an aspirin-free approach with potent P2Y12 inhibitor monotherapy immediately after PCI effective and safe? So they chose a study population of adult patients presenting with all types of ACS from STEMI to unstable angina who had successful PCI for the culprit vessel. And this was all done within the first 4 days of hospitalization. People that were excluded is anyone in whom the planned DAPT duration was less than 12 months, if there's residual CD that needed intervention in 12 months' time, if they needed anticoagulation, if they had major bleeding, if they had an ischemic stroke or ICH. So the study design was that the patients were randomized to either, so they would get their PCI, and then they're randomized to either stopping their aspirin, and then were switched to a potent P2Y12, which was prasugrel or ticagrelor, versus continuing to do antiplatelet through the aspirin and a potent P2Y12, prasugrel and ticagrelor for 12 months. They had routine follow-up at 1 month, 6 months, and 12 months after randomization. So there were 2 ranked primary outcomes. So a composite of death from any cause, MI, stroke, or urgent target vessel revascularization. I can see Dr. Bernie's disapproval. And then secondly, major or clinically relevant non-major bleeding. So when you look at the baseline patient characteristics, so the mean age is 60 years old, about 29% of the patients were women, a third had diabetes, 62% had STEMI at presentation, 20% were high bleeding risk. Interestingly enough, I think this is more reflective of geographic trends to antiplatelet choice. Most patients, almost 100%, were on aspirin and clopidogrel as the index choice of treatment. After randomization, 70% were on prasugrel and 30% were on ticagrelor. So the regional choice in Brazil seems to be default Plavix, but if you need potent antiplatelet inhibition, it's prasugrel. Whereas the North American practice is typically aspirin, ticagrelor upfront and prefer to treat with ticagrelor. The median time for hospitalization randomization was 2 days. So the results. The primary outcome didn't meet the pre-specified criterion for non-inferiority. And since non-inferiority was not shown for the first primary outcome, the formal hierarchical testing for the bleeding outcome wasn't done. So effectively, at 12 months, death from any cause, MI, stroke, or urgent revascularization occurred in 7% of patients in the monotherapy group and 5.5% of the DAPT group. Major or clinically relevant non-bleeding was slightly higher in the dual antiplatelet therapy group at 4.9% with a hazard ratio of 0.4 and 2% in the monotherapy group. The bottom line was they failed to demonstrate that an aspirin-free monotherapy strategy immediately after PCI was non-inferior. They couldn't demonstrate that. But we did note from landmark analyses that at the 30-day mark, there was an excess ischemic risk, but after 30 days, the outcomes were pretty similar. At 30 days, there was typically excess bleeding in patients that were on dual antiplatelet therapy, but more ischemic risk in those that were just on potent single antiplatelet therapy. So the question here is, yes, short dual antiplatelet therapy regimens might be helpful. Single antiplatelet therapy immediately after PCI is probably not good. So looking at the dual PCI as well as the neo-mindset study, any thoughts on that? If anyone has any questions? Online as well, actually, or anyone online as well. Yeah. No.
Transfusions or
It was, sorry. It was usually like BARC 2, 3, or 5 bleeding. So it was either major bleeding or clinically significant bleeding that was non-fatal. No, those specifically, I didn't look through the appendix for that kind of information, but this was kind of like an all-comer population. Yeah. So I think from a clinical perspective, we have the bearing that, hey, we have a question there?
Sometimes get these referrals in the cath lab where a patient has an aspirin allergy. They come from home, they're stable angina. They haven't been desensitized, then they show up, the morning of, we see them, or so. Do you go ahead and PCI these patients? Do you take them off the table and desensitize them? I've done a few recently, big vessel, and we just treat them with monotherapy. We just give them Tyvaso or monotherapy. We don't even give them of aspirin when the allergy is real. So with this change, how we should treat those patients, should we request that anyone come to the cath lab with an aspirin allergy gets desensitized first? Should we, stage in a later date? What do you think?
Yeah, I think that's a great question. So the first thing is, what's the patient population? If it's a stable CAD population, I don't think the risk of, ad hoc PCI on single antiplatelet therapy would necessarily be justified, in which case I would consider for stable CAD patients in which you find multivessel disease or PCI is needed, for example, I'd consider, doing desensitization and then doing the PCI. In ACS populations, clearly, we have data that a short strategy, like just single antiplatelet therapy is sometimes insufficient. I think you have to individualize to patient clinical characteristics for bleeding and ischemic risk. But I would feel very uncomfortable just putting them on a single antiplatelet agent, no matter how potent it is. I've seen interesting strategies. Some people will, because we do this in the AFib population, will do an anticoagulant. I've not personally done this, and concurrently say an antiplatelet agent. But my preference would be to desensitize these. I'm not sure if anyone has any different practice patterns, but I'd feel nervous about, just leaving them on a single antiplatelet immediately after index PCI, especially based on this data from ACS populations. And the stable populations, well, you have time, so might as well desensitize them. Okay. So I think slightly changing tack a little bit and talking about LV dysfunction. So beta blockers are foundational therapies in acute MI. Early RCT showed dramatically reduced lower risk of death in AMI patients up to 23% who were on a beta blocker. These trials were kind of mostly done prior to the reperfusion era and prior to primary PCI. There was recently the reduced AMI trial that showed that patients that have LVEF of 50% after AMI showed no benefit in beta blocker therapy. The guidelines in 2025 ACC-AHA continue to issue a class 1 recommendation for beta blockers after an acute AMI. So I think it's important now, and what we're doing, it looks like, as a scientific community, is looking at different thresholds of LVEF reduction. So what is the role of beta blockers in patients with normal to mild LV dysfunction post-ACS? So the REBOOT trial was conducted across 109 centers in Italy and Spain as a prospective open label RCT. So the research question was, does beta blocker therapy in patients with acute MI and preserved or mild reduced LVEF lead to a lower risk of composite of death from any cause, reinfarction, or hospitalization for heart failure compared to those on no beta blocker therapy? So they took all comers with ACS that had invasive management of their CAD, and then had an LVEF of greater than 40% on discharge. So anyone who had a contraindication for beta blocker, if they had a beta blocker indication unrelated to their MI, or had a pre-existing history of heart failure, including KILIP2 during hospitalization, was excluded. The trial design was the patients were, assigned in a one-to-one fashion to beta blocker treatment or no beta blocker treatment, and it was performed at the time of hospital discharge or within 14 days of discharge, and the treatment began at the time of randomization. Roughly about 4,000 patients in each arm. The mean time from acute MI to randomization was about 4 days. The mean age of the patients was 63. And again, this is pretty consistent across all 4 trials. It's like mid-60s males predominantly included in these studies. About half had hypertension, 20% had diabetes, about half were smokers. Interestingly enough, 75% were already on ACE inhibitor, and 92% were treated with PCI, with almost 90% having complete revascularization. The beta blocker of choice in the beta blocker arm was overwhelmingly bisoprolol at 86% and metoprolol at 7.5%. So the median follow-up was about 3.7 years, and the primary outcome of death from any cause, reinfarction or hospitalization for heart failure, happened in 316 patients in the beta blocker group, and in the no beta blocker group, 307 patients. So what does this mean? Among patients who have been discharged after invasive care for a ACS and had an LVEF of greater than 40%, treatment with beta blockers showed no evidence of an effect in the incidence of death from any cause, reinfarction, hospitalization from heart failure. So these are pretty consistent with several meta-analyses as well as a prior reduced AMI trial. I'd be interested to see if the LVEF cutoff drops to, we went from 50 to now 40, whether someone will, have the courage to say, well, what about patients with acute AMI and reduced LVEF? What about beta blockers up front? Contemporarily, what we see is these patients come in with ACS, we start them on GDMT, we repeat the echo in a few months, and the LVS have improved, and we start tailoring, cutting back on treatment. So is the ACS LV dysfunction population any different than, say, LV dysfunction from any other cause? Any questions about that study? Dr. Stadnik. So let me see here.
Well, I would argue that 57%.
Of course, yeah, that's true. It might just be the same study. Yeah. So it's just probably reduced AMI done with a more inclusive mindset, but ultimately the same patient population. What are your thoughts on the concept of just, ACS LV dysfunction patients independent of this study? Like, would, say, if the trial had predominantly included LVF of 40%, do you still recommend we consider treating with beta blockers? Yeah.
It's just in this particular trial, I would actually.
It's only 12% of patients that had, EF less than 50%. Mhm. The only reassuring thing is it was an 8,000 patient trial. So substantially with 4,000 patients in each arm, even 12% of that would still be fairly large for an RCT from an event rate perspective. But that was a very good point. No, I don't either. So moving on, 2 more studies left. So we can't forget our EP colleagues. So this is the Alone AF trial. So Clearly, catheter-based ablation for atrial fibrillation has been superior for maintaining sinus rhythm and improving quality of life. What are the thromboembolic long-term outcomes in patients who have had successful catheter ablation, which of course we know is 100%. So current guidelines recommend continuing DOAC even after successful ablation in select patients with increased thromboembolic risk. So the ALONE AF study was another South Korean trial that was investigator-initiated, open-label, multi-center, conducted across 18 centers in South Korea. So the research question was, in patients without recurrence of atrial arrhythmias after catheter ablation and at least one non-sex-related stroke risk factor to stopping the oral anticoagulant result in superior clinical outcomes compared to continuing OAC. So, I think back to patients that I've seen in clinic who had a successful AFib ablation, 3 years ago, have had subsequent Holters and ECGs since, have a normal sinus rhythm, and say, well, I get bruised all the time and I'd rather not be on an anticoagulant. If I stop it, do you think I'll have a stroke? What do you think? And I think this trial is geared to answer the question for that particular patient population. So they included patients that were age 19 to 80 that have a history of atrial fibrillation who had successful ablation with a CHA2DS2-VASc score of 1 in men or 2 in women. So arrhythmia recurrence, they defined it as any documented episode of atrial arrhythmia lasting 30 seconds or longer for atrial fibrillation, flutter, or tachycardia. And they assessed this after ablation by using at least 2 separate Holter studies, 24 or 72 hours over the 1-year post-ablation time period. The only qualifying thing with regard to the Holters was that one of the Holters must have been done 2 months prior to enrollment and randomization. So if you look at the patient characteristics, mean age is 64-year-old patients, 75% were men, 568 had paroxysmal atrial fibrillation in total, which is about 2/3 of the patient population. And the mean duration between the catheter ablation for AFib to randomization was 3.6 years. The mean CHA2DS2-VASc and Hasbled scores were roughly equal at 2. And the mode of ablation was predominantly RF ablation in 85% of the patients, with remaining undergoing cryoablation. PVI was performed in all cases. So the primary outcome was the first occurrence of a composite of stroke, systemic embolism, and major bleeding at 2 years. If you look at the oral anticoagulant arm, 78% were on apixaban 5 milligrams twice a day, and about 7% were on Riva 20 and 9% were on Riva 15. So they were randomized to either cessation of oral anticoagulant or continuing it. So the primary composite outcome of stroke, systemic embolism, and major bleeding occurred in 1 patient in the no OAC arm and in 8 patients in the DOAC arm. There were some criticisms about this trial, but largely the conclusion that the authors claimed was that among patients with documented atrial arrhythmias after successful catheter ablation, discontinuing the oral anticoagulant resulted in lower risk of composite outcome of stroke, systemic embolism, major bleeding, and continuing the oral anticoagulant. When you look at the composite outcome, however, you've combined ischemic and bleeding events within the composite primary, which clouds judgment as to where the benefit really lies. Is it with the ischemic events or bleeding events predominantly? This is also a pretty heterogeneous population that includes both paroxysmal and persistent AFib. The other thing is observational data, large cohorts have shown that not all successful AFib ablation patients are the same, meaning those that have CHA2DS2-VASc scores of 2 or higher may still benefit despite not having recurrence of the arrhythmia with a reduction in the thromboembolic risk. Any thoughts from our EP colleagues on this study? Pretty consistent with what we do in clinical practice. Does anyone routinely discontinue? I'm just curious from the EP side, do you typically discontinue OAC, say, 2 years out and they've had an ablation, or do you continue it largely? It's a reverse. I'm asking questions more for my own knowledge. Awesome. So you can't say anything. Sounds good. I wasn't sure if he was smiling or not.
But this was a very underpowered study, and in clinical trials 101, you cannot combine your primary efficacy and your primary safety outcome with the same outcome. And so we've just completed the ocean trial. Think a better study, and we did cerebral MRIs in everybody at baseline in 3 years, so we have much greater power to answer this question. We're presenting at American Heart in 3 weeks' time.
For those that are on virtually, Dr. Bernie just said Ocean's being presented at American Heart soon. I mean, obviously, we haven't tied into other things. What about our structural and other EP colleagues that do LA closure? How does that factor in when you think about, two competing therapies that may perhaps, mitigate a thromboembolic risk? So either stopping the DOAC or anticoagulant or, doing LA closure. But I think that's a different study. So the best for last, and I think it's for our heart failure colleagues, the DIGIT-HF trial, which I found personally the most exciting out of ESC 2025. So, cardiac glycosides, and I'll say cardiac glycosides and not digoxin because of, the drug in this study, have been used in treatment of heart failure for 200 years, well documented. So the DIGIT trial, which you all recall in 1997, clearly because you were all in clinical practice at the time, reduces hospitalization in patients with severe LV dysfunction, but it didn't impact mortality among patients with HFrEF. The other thing now, since that trial has been published, they found that low serum concentrations of digoxin were associated with better clinical outcomes, whereas if you had higher serum concentrations, say 1 nanogram per milliliter, they had worse clinical outcomes. And that speaks to something we all know intuitively, is that digoxin has a very narrow therapeutic threshold, as a high chance of toxicity. So when the study was done in 97, you didn't have widespread use of MRAs, you didn't have SGLT2 inhibitors, you didn't have neprilysin inhibitors, you didn't have ICDs or CRTs at the level of prevalence that we're currently using them. So the reason why I say cardiac glycosides is there's more than one. So there's digitoxin, unfortunate branding in the name, but digitoxin, it's the other clinically relevant glycoside and has a unique formulation from a pharmacodynamics perspective. So in patients with renal impairment, it has fairly effective enterohepatic excretion. So even if you have patients with renal failure, they'll reliably not become, DIG toxic, so to speak. It also has more stable blood conditions, even with those with renal dysfunction. It hasn't been studied in RCTs. So this was a phase 4 blinded RCT of 65 sites in Austria, Germany, and Serbia. So the research question was, does digoxin therapy in patients with chronic heart failure and reduced LVF decrease the composite outcome of death from any cause or hospital admission for worsening heart failure when compared to placebo? I think that's a pretty fair, outcome, the way it's been phrased. So, patients who are 18 or older that have symptomatic heart failure with LVF less than 40% and NYHA 3 or 4, or LVF less than 30 with NYHA 2, and were on GDMT for at least 6 months. So patients were randomly assigned in a 1-to-1 ratio to receive digoxin at a starting dose of 0.07 milligrams daily, or matching placebo. They had dose adjustments that were based off of serum concentrations at 6 weeks. And if they were out of target parameter, the dose was typically adjusted either by a decrease to 0.05 or an increase to 0.1 milligrams per daily. Randomization was stratified by sex, NYJ class, AFib, or So from a baseline characteristic population, so 600 patients were randomized to each arm. The median follow-up was 36 months. And mean age, again, 66-year-old patients, predominantly male, about 80%. More than 70% had NYHA class 3 or class 4 heart failure. The mean LVEF, Dr. Static, was 29%, and 27% had atrial fibrillation. So interestingly, this is, maybe the Hawthorne effect, but exceptionally well-treated patient population, I would say, as a non-heart failure doctor. 93% were on beta blocker and RAS inhibition. 76% were on MRA, 19% were on SGLT2 inhibitors, 64% had an ICD, and 25% had CRT. Those are pretty good numbers. I wonder where we stand. I hope all patients have this level of treatment. So what did they find? So the primary outcome of death from any cause or first hospitalization for heart failure occurred in 39.5% of the digitoxin group and 44% of the placebo group. So from a safety perspective, at least one serious adverse event occurred in 4.7% of the digitoxin group and 2.8% of the placebo group. And drug discontinuation was about the same in both, in the placebo and the digitoxin, so 9% and 10%. So the bottom line from the study was treatment with, this should say digitoxin, led to a lower combined risk of death from any cause or hospital admission for worsening heart failure compared to placebo in patients with heart failure and reduced EF who are already on GDMT. So the question is, if our heart failure colleagues agree, is that the time for quintuple therapy, or should we consider this an all-comers based off of the study, or is more data needed? This was a phase 4 control trial. I think the most prominent representative from the heart failure group is Dr. Stadnik. You haven't the lone representative. Do we have a mic? Excellent.
So I think there's some subtlety that our fellow isn't here. That's our fellow went into yesterday, and I'll summarize his work. So this trial took a very long time to enroll. So over a decade, I think, to enroll. They never hit their original target enrollment numbers. So there were many protocol amendments along the way. And in fact, when you look at the number of patients that actually stopped therapy along the way, it actually was about half of the patients in each group. So just from a trial perspective, there were a lot of things that happened along the way with this trial. The second practical issue is that digitoxin is not the same as digoxin, and you cannot get digitoxin in North America. So from that perspective, this is a moot point in our world. Because they are not the same drug. So we have to be careful about that. The other issue is, if you look at the amount of VF, and there's a table that looks at, if I put in the appendix here, the amount of VF is higher in the DIG group. Now the numbers are really small, but you know, we only had about
600 in each.
200 people in each group that actually went through the therapy as intended. Now, it was an intention to treat analysis, just do it, but so there's a lot of nuances, I think, when you dig into this trial that aren't immediately apparent in just the summary tables. So is this going to change my practice? Well, no, I don't have digitoxin access.
It did.
And even if I did, probably not with just this one trial. Probably not. And I think the other important thing to remember is we look at the curves and how much they deviate. It's not a big difference. And you've got patients now that are already on 4 or 5 drugs. If there's a reason that people stop taking stuff, and you're already on 5 therapies, let's say, and somebody says, oh, I'm actually add another one for a nominal absolute risk reduction and potential harm, although, you know, not statistically significant in this trial. I just think there's a practicality to this that needs to be.
That's very helpful. One thing I think about with heart failure management, at least the challenges I face, is all of the quad therapy agents are either vasoactive or affect the kidneys. I was like, well, wouldn't it be nice to have something with a tolerable hemodynamic profile that isn't dependent on renal clearance? It would be nice to have something like that. I agree. I think the major limiting factor is if you had a 5th therapy, people aren't going to want to take, 10 tablets a day. But would you think it's promising to have a drug like this that you may be able to substitute for someone, say, who has hypotension or is challenged with renal dysfunction? I don't think anyone's ever going to do a digitoxin, single therapy trial in HFrEF, but it seems like a decent option if it ever is available in North America. Dr. Lamanaz?
For benefit, patients who had less than 30, patients whose blood pressure is low. Exactly one of the problems we struggle with in heart failure patients, that I see a lot of them as well, is that they can't take the 4 drugs. That's their blood pressure is 85 over 55. They're on, 2 of the drugs or 3 of the drugs. And I thought that there was something, some subgroup that showed that in that group of patients, there was actually amplified there. No?
I have to review. I mean, yeah.
There is a large 30 different groups that they did, but again, the numbers are small, right?
But I mean, yeah, I think,
Of actually the same on the effect of difference how it's steered. So I think, it's probably a safer drug than digoxin because you don't run into the problems of toxicity of renal dysfunction. But if you monitor these patients carefully and you keep their levels, below that UO1, then personally, I think that this does have a role, and starting to use it these tricky patients that, I get sent for an R reduction, they don't have an R, they have heart failure.
right. Yeah, I mean, the nice thing about the study, even if, 600 were randomized to each arm, say 50% of drug discontinuation, so that leaves you with 300 in each arm. And then of those, about 150 in each arm had EFs of less than 30%. So that is not an insubstantial amount when you compare, overall how many were treated. But I think all very good points. Thank you all. So the takeaways from this, number one, in patients with STEMI, consider staging non-copper lesions in patients with heart failure, meaning don't do it right away, which I think most of us take that approach. Shorter DAP duration of 3 months post-ESCS may have lower mortality and bleeding risk compared to 12 months, which is in dual ACS. There may be excess ischemic risk with single antiplatelet therapy, no matter how potent the P2Y12 is, immediately post-ECS compared to dual antiplatelets at 30 days. That's from the NEO-Mindset trial. In patients with documented atrial arrhythmia recurrence after catheter ablation for AFib, stopping the DOAC results in a lower composite of stroke, systemic embolism, and major bleeding from alone AF. Hopefully, more light will be shed on this with OCEAN, which is going to be a larger trial. Patients with invasive treatment of MI with an EF that is greater than 40%, with the caveat that a lot of these patients actually preserved EF, to Dr. Static's point. Beta blocker treatment did not have an effect on death from any cause of reinfarction or hospitalization in the reboot trial. And finally, digitoxin treatment led to a lower risk of death from any cause or hospital admission for heart failure among patients with heart failure and GDMT from the DIGIT-HF trial. So those were some trials from ESC 2025 that I think offered points of, maybe change of practice to a degree, with caution, obviously, as more RCTs and guideline recommendations and meta-analyses need to be updated. But thank you all for your attention, and that's it.
One more question, chat for Dr. Journey. Dr. Bean is asking, how does alone differ from OCEAN in terms of
The primary endpoint is different from ours, the cardinal error of combining safety and efficacy, which ours is only efficacy. You didn't have stare blood in their eyes, so, they're gonna miss lots and lots of small strokes.
Thank you very much.
All right, thanks everyone. Have a great day.
Excellent presentation. Thanks. Next week, it's going to be